This video will address these topics through 5 multiple-choice questions. You may follow the sequence or locate the timestamp of each multiple-choice question in the description.
Multiple choice question number 1.
A 15-year-old girl reports severe vomiting for 3 days. She also has a concurrent viral infection. Her fatigue and lack of energy have persisted for 3 to 4 months. At examination, she exhibits a BP of 80/50 millimeters per mercury, pulse of 130 per minute, and enhanced pigmentation in her buccal mucosa and nipples. Urinalysis is normal. Her sodium levels are 118 millimoles per liter, or 135 to 145, and chloride levels are 76 millimoles per liter, or 95 to 110 in her blood. Which is the most plausible reason for her presentation? A. The Addison disease. B. Congenital adrenal hyperplasia salt losing. C. Chronic fatigue syndrome. D. Chronic reflux nephropathy. E. Thyroid crises.
The answer is A. Addison disease causes cortisol and aldosterone insufficiency due to adrenal cortex dysfunction. Symptoms include weakness, nausea, vomiting, hyponatremia, and hypotension. Under stress, her adrenal steroid deficiency causes circulatory decompensation and hypotension. Low cortisol increases ACTH, with hyperpigmentation of mucosal membranes and nipples are present. Other options. Salt-losing congenital adrenal hyperplasia, CAH, is a genetic enzyme deficiency causing cortisol and aldosterone shortage. Here, the onset is acute and hyperpigmentation is rare. Chronic fatigue syndrome, CFS, causes persistent tiredness but does not cause hypotension, electrolyte imbalances, or hyperpigmentation. Chronic reflux nephropathy primarily affects the kidneys and presents with signs of renal impairment, proteinuria, or hypertension, not hyponatremia and hyperpigmentation. Thyroid crisis presents with tachycardia, fever, agitation, and sweating, but not with hyperpigmentation, hyponatremia, or hypotension as primary findings.
Multiple choice question number 2.
A mother brings her 3-month-old daughter in to address some concerns with diapering. The delivery was vaginal and the infant was breech. Everything else is fine with the baby. On examination, one hip showed restricted abduction. If you suspect congenital dislocation, hip developmental dysplasia, what other clinical sign would you use to make a diagnosis? A. Groin crease lines that are not identical. B. Leg length inequality. C. An extended hip that clicks. D. A jerk as the hip is flexed and abducted. E. The internal femoral version of the hip.
The most helpful clinical finding to confirm developmental dysplasia of the hip, DDH, in this 3-month-old infant with limited hip abduction is D. A jerk while abducting the flexed hip, Ortolani sign. Here's why the other options are less specific or less reliable. A. Creases may be uneven in normal infants. B. Leg length inequality. May appear later, not sensitive in early infancy. C. A clicking hip on extension, common and often benign due to ligament laxity. E. Internal femoral version of the hip, a rotational deformity not diagnostic of DDH.
Multiple choice question number 3.
The patient is a 39-year-old male with sickle cell anemia who presents with a cough, sputum that is rusty in color, and chills that are accompanied by trembling. On palpation of the left posterior chest, the examiner has detected rales as well as bronchial breath sounds. The patient's phlegm harbors S. pneumoniae that is resistant to penicillin. In this particular strain of S. pneumoniae, how does penicillin resistance develop? A. The synthesis of penicillinase. B. The decrease in penicillin permeability to cell walls. C. Changes to the penicillin binding protein. D. The penicillin efflux pump. E. Cytoplasmic porin downregulation.
The answer is C. In Streptococcus pneumoniae, penicillin resistance is primarily due to changes in penicillin-binding proteins, PBPs. Mutations alter PBPs, especially PBP2X, PBP2B, and PBP1A, reducing their affinity for penicillin, which prevents the antibiotic from inhibiting cell wall synthesis effectively. The other options: synthesis of penicillinase. This mechanism, common in Staphylococcus aureus, does not occur in S. pneumoniae. Decreased penicillin permeability. Resistance due to altered permeability is more typical of gram-negative bacteria, not S. pneumoniae. Penicillin efflux pump. There is no significant evidence for an efflux pump-mediated penicillin resistance in S. pneumoniae. Cytoplasmic porin downregulation. Porin-related resistance is mainly seen in gram-negative bacteria, not S. pneumoniae.
Multiple choice question number 4.
A man who is 35 years old is complaining that he cannot shut his right eye. During the examination, it was discovered that the right side of the face, including both the forehead and lower face, is affected by facial nerve paralysis. All other neurological examination findings are within normal range, and no additional abnormalities have been detected in the cranial nerves. Coldness has not yet set in. No further abnormalities were detected during the examinations of the skin, abdomen, chest, and heart. A lack of lymphadenopathy is noted. The patient visited a dermatologist around 1 month ago after returning from a camping trip with a bullseye skin rash. Based on the symptoms, which diagnosis is most likely correct? A. Sarcoidosis. B. Idiopathic Bell palsy. C. Lyme disease. D. Syphilis. E. Locular infarct.
The most likely diagnosis is Lyme disease, option C. The patient presents with unilateral facial nerve weakness involving both the forehead and lower face, consistent with lower motor neuron facial palsy. The history of a bullseye skin rash, erythema migrans, occurring 2 weeks after a camping trip strongly suggests Lyme disease, which is a tick-borne infection known to cause such skin findings and subsequent neurological complications, including facial nerve palsy. Other options are less likely given the absence of systemic symptoms: sarcoidosis, unilateral nerve involvement and the specific rash, idiopathic Bell palsy, syphilis, or the pattern of neurological deficit. Lacunar infarct typically causes upper motor neuron facial weakness, sparing the forehead.
Multiple choice question number 5.
A 67-year-old man presents in ER in mid-August with fever, headache, confusion, and right-sided weakness that developed over 2 days. He has diabetes controlled by oral medications and spends time gardening daily. Exam shows neck stiffness and weakness, 4-5, in the right arm and leg, but no cranial nerve deficits. Brain CT is normal. Lumbar puncture shows 158 white blood cells, mainly lymphocytes, 21 red blood cells, normal glucose, and mildly elevated protein in cerebrospinal fluid. Which of the following is the most likely diagnosis? A. Embolic stroke. B. West Nile virus, WNV encephalitis. C. Subarachnoid hemorrhage. D. Bacterial meningitis. And E. Tuberculous meningitis.
The most likely diagnosis is B. The patient's fever, headache, confusion, focal neurological deficits, and lymphocytic predominant CSF with normal glucose and mildly elevated protein fit the profile of WNV encephalitis, a mosquito-borne viral infection common in late summer. Other options: embolic stroke typically presents abruptly without fever or CSF pleocytosis. Subarachnoid hemorrhage usually presents with sudden severe headache, and early CT is often positive. Bacterial meningitis often shows neutrophilic CSF pleocytosis, low glucose, and higher protein. Tuberculous meningitis has a subacute presentation with lymphocytic CSF, but often low glucose and elevated protein.